Okay, so the topic today is discussing SUDEP, and I really do mean the discussion part of the topic. There are a variety of other topics within SUDEP that we could talk about, like the basic science and or preventative measures, and I've left those out because it gets too big to talk about in a short period of time, but have tried to keep my talk brief enough so that if you have questions, please ask them, and if we don't get them answered here in this setting, then I'm happy to talk to you later. So the purpose of disclosures in giving talks is to let the audience know about biases on the part of the speaker. And I want to let you know that my relevant disclosures is based in my high sense of bias towards this topic. You're not going to get a neutral talk about SUDEP. That's not gonna, you're not going to get that from me. You'll may get from somebody else. But as talking with the Olsons, I've been involved in this community now for a number of years and just seem to get sucked deeper and deeper, even though it's probably the most unpleasant thing I do as a professional. I have some irrelevant disclosures, like I've served as a consultant for UCB and Eastside and Upshur Smith, who I think have been positive forces in the epilepsy world. So the topic today is the discussion of SUDEP, and these two titles from papers that are relatively recent, 2006, sort of summarize it. To discuss or not discuss, that is the question. SUDEP, don't ask, don't tell. And one of the points that I'd like to make about this topic is that it's relatively new. In 2006, not very long ago, these were relevant questions. And I think you'll see that there's been a lot of progress made in the last few years. So I've organized the talk excuse me, around these four topics. First, essentials, which is really the background and context of SUDEP. The second, a briefer conversation about what's the ethics of the discussion, the ethical obligations one way or the other. I'm going to spend the vast majority of the time talking about the evidence for the discussion of SUDEP, meaning what professionals do and what families want. And I'd like to pause for a second just to say, and this is very relevant to the CBD conversation, it's the evidence that moves things. It's the evidence that changes what payers do. It's evidence what causes politicians to do and what causes government to do. So in my only, well, maybe not, only political statement, I would say if you want to move CBD into the mainstream, the most important thing to do is to advocate at a governmental level for research, because that's where it's going to be decided. And it would be a crime if in 10 years we're still having the same discussion when you have distinguished speakers answer questions with, we don't know, because we don't know where the research is. And it's sort of odd that in the area of SUDEP discussion, we do have evidence. So that's my political statement. And finally, I'll end with the topic of empathy as to why we should be discussing this tragedy. So the essentials. When you get to be a certain age, you think that history is interesting and relevant, and I do. So this was a paper from 1868, and it bears reading. The immediate cause of death in epilepsy is a matter which is not always easily solved, and one which is not often discussed in works on medicine, most probably from lack of information. How relevant is that? This silence on the part of writers is not to be wondered at when one considers how few epileptics die in hospitals or under the observation of the more learned teachers of medicine. And what that hint was, which we ignored for about 100 years more, is that we in hospital settings, who are supposed to be the great thinkers, don't see most of the deaths from epilepsy. For as such patients are generally incurable and also unpleasant companions, not so much. They seldom figure long as inpatients. But there's another cause far more active and connected with the nature of the disease. That, inasmuch as the mind always suffers from prolonged epilepsy, in a certain time, the victims of this disease, or at all events, a large proportion of them, disappear from society and require seclusion in an asylum where they are lost to the world. The silent deaths. Now, this is 1868, and it is easy to get sucked into history. This is a very active issue. This little boy is Henry Lapham, the son of Gardner and Nick Lapham. And Henry had a few simple febrile seizures at the age of 3. At the age of 4, he began having seizures in the morning, convulsive seizures. He was seen by a very good pediatric epileptologist and started on oxcarbazepine. And he died 5 weeks after the first afebrile seizure before an MRI or his medicine target could be reached. He had an autopsy and it was unrevealing. And in many ways, Henry's situation is one of my bottom lines, is that it is never too early to broach this horrible subject. No one wants to talk about it. No one. Doctors, nurses, certainly families and affected people with seizures. But it's an important conversation, and just because it's unpleasant doesn't mean we shouldn't do it. Now, where does SUDEP fit in the world of mortality, death related to epilepsy? And this is a list, I think, that all physicians would construct in 5 minutes or less. It's not a hard list. And until very recently, very, very recently in history, SUDEP would probably be close to the bottom of the list. We must never forget that children and adults with seizures have underlying neurologic issues, and their fate regarding mortality can very frequently be determined by what the underlying cause is. Now, in a review article done by Dr. Ficker about 10 years ago, he went through the literature of mortality in epilepsy just to ask the question, in general, what are the causes of premature death? And this is the list from the paper, and a lot of us, including me, were very surprised that SUDEP greater than 10%. And when you look at the list, the only number greater than 10% is infections, really, of the nervous system. And that's 20%. So this was something of an early wake-up call to the importance of SUDEP in the context of premature mortality. Now, one of the issues that is frequently brought up is that, of course, SUDEP is horrific. Of course, premature mortality in epilepsy is terrible, but it's not very frequent, and therefore not a national healthcare problem. There were numbers floating around in the early days of SUDEP, meaning the last 5 years, that said 50,000 Americans each year die because of SUDEP. And that was promulgated on a whole bunch of presumably reliable websites. It's, for those of us who do it professionally, that seemed like a wildly high number. And in fact, it was. When good epidemiologists looked at it, the number is closer to about 3,000, which is 3,000 too many. But that said, on a national scheme, you say, well, gee, how many dollars should we put into SUDEP research if only 3,000 people die a year? Because there are greater needs. And in this paper that was published in 2014 by Doctors Thurman, Hestorfer, and French, they looked at the information differently. They looked at it in terms of annual years of potential life lost due to selected neurologic conditions, looking over a lifespan. And what they found was that SUDEP was second only to stroke in number of potential years, life years lost. Why is that? Because SUDEP typically affects young people. And as soon as you say that, then you can begin to appreciate the impact over a lifetime and lost years. So I think this was a very powerful statement of the importance of this topic. What is SUDEP? One has to have a definition. And there are a few, but let me give you the two that exist now that are commonly talked about. The first was 1997 from Dr. Lena Nashef in Great Britain, and a virtually same definition from Dr. Fred Anniger's University of Texas. Sudden, unexpected, non-traumatic, and non-drowning death in an individual with epilepsy, with or without evidence for a seizure, and excluding documented status epilepticus where post-mortem examination does not reveal the cause of death. And so, in order to be sure that someone truly died of SUDEP, there needs to be a post-mortem examination. Tough stuff to lose a loved one, and in that immediate period, be confronted with the idea of a post-mortem examination. And on so many levels, people want to push this away. One of the things, however, and again, a tough stuff point to make is this is very important. Number one, to really know what happened, and number two, to make progress in the field, to do research, and to understand how to potentially prevent in the future. And I'll come back to that at the very end, just to make the point. Now, in 2012, a number of folks that are active in the field said, gee, it's been more than 10 years. We're trying to do better research, but that definition isn't stringent enough to know exactly what we're dealing with so that we can have greater understanding. So they created a unified definition of SUDEP that has a lot more detail, and that I'm not going to go into in any detail other than to give you the key features. And again, does it make a difference to the bereaved? No. Does it make a difference to understanding what happened and trying to do better in the future in research? Yes. First thing is to be able to specify, was this with or without a witness seizure? To specify, was there an autopsy done or not? The concept of including dry drowning, meaning if prior to this definition, if someone with known epilepsy died while swimming, it would be automatically assumed this was just a drowning and therefore not really a SUDEP. But as you can probably guess, People with seizures are at great risk of drowning if they have a seizure when they're in the water. And so this was a way of trying to include those folks. You need to specify if there are known competing causes. If someone has a brain tumor, if someone has a severe mitochondrial disorder, that needs to be factored in. Also needed to say how long after the seizure could you consider something to be a SUDEP. And they also included at the back of the article a number of examples of how one would classify these things for inclusion. So this was an important paper to move the field forward. This is just a big blue box with definitions of definite SUDEP, SUDEP plus, probable, possible, near, not SUDEP, and unclassified. So again, this is just to help people understand the likelihood that something really was an unexplained cause of death. Now, epidemiology. Epidemiology is the study of many things, but for our conversation today, the importance of it involves risk factors. Because in the office, folks want to know, what is my risk? What's the risk of for my child? And how do we know these things? And how does that influence the conversation? So, who's the most susceptible? Some of the lingo in this epidemiologic literature, and this is just so I can help you read the next two slides. So when we say patient years, it allows looking at a group of people rather than an individual. So patient years, the total number of all years that all patients were followed, and considering the number of events of interest. So if 10 patients were followed for 10 years each, that would be 100 patient years. And you'll see data that says 1,000 patient years. If it was cancer, if there was one case in this group, one person, then it would be one person per 100 patient years. And that's how the data is expressed. So what you see, what your numbers are, depends on where you're looking. And let me show you what I mean. So this is a series put together by a Swedish researcher who's been very important in the field, Torbjörn Thompson, of studies that report SUDEP from the community. And you see they're from the USA, from the United Kingdom, Ireland, and Australia, community-based. Most of the studies are retrospective, so looking back and identifying people. When one looks at these numbers, I always wonder how the little blue box gets moved. It's supposed to be over this way. It's just to highlight, you see numbers like 0.35, 1.3, 2.3. That's where the numbers per 1,000 patient years comes in. And it may seem small, and epidemiologically is small, of course, unless it happens to you, unless you're Gardner Nick Lapham. And so the range in community-based studies is 0.9 to 2.3. I want to draw your attention to this line right here. This was a prospective study. So saying we're interested, so we're going to follow people forward in time. And what you see here is 0.09, which is, 10 times less than 0.9. The idea here is that as one does better and better science, you get better and better answers. And I'll make that point again for the whole CBD discussion. Unless you do it properly, you just don't know. Now, let's look at another group of patients in epilepsy populations. And so these are populations drawn from epilepsy cohort from a hospital, epilepsy centers, epilepsy clinic, tertiary referral center, residential care, refractory epilepsy, vagus nerve stimulator study, epilepsy surgery referrals, surgery candidates not operated on, continued seizures after surgery. The numbers in the blue box are now much larger because this is a population of people who have so-called intractable epilepsy. And the numbers are greater, 1.1 to 9.3. So the risk goes up. This is a graphical representation of the same information from the greatest risk to the least risk. And down here at the least risk, and I'll make this point probably another slide or two, are most children. So, you know, it's a difficult issue for doctors to discuss something horrific in a population where it's unlikely to happen. But it certainly does. So what about other risk factors? Age, cause, and seizure control. A study that was published in 2010 was I think, one of the more influential papers in the literature because it was prospective, it was population-based. You don't have to go if you don't want to. It's fine by me. Seriously.
I'll hang out here. I'll watch the rest from home later.
Okay, but part of pediatric populations, if I was sensitive to children crying, I wouldn't go to work every day. Population-based and 40 years of follow-up. That's almost unheard of. Just to know, this is childhood onset epilepsy, not mortality in childhood. So this is what happens when you follow individuals from onset when they're kids. And I want to take you through the data here because I think it's very revealing, because it's evidence. So in this publication, of the 245 people that were followed from childhood, there were 60 deaths. 45 of the 60 were in individuals who there was a known cause of epilepsy. So the cause was known. And this sort of goes back to the question I believe you were asking about cause. And I'm very, I have internal dissonance on this issue. There's a ton of different causes of seizures. And so is it fair to group them all together? And the answer is no, if you're a purist and want to attack the cause, and yes, if you want to try and group them in a way that's meaningful so that you make larger statements. So I don't know how to do better than that. And so when we group them, they're called symptomatic, which just means the seizures are a symptom of something, and you know what it is. And so what you see is the majority of the deaths were in that population, symptomatic. Another clue in this paper is that 85% of these individuals were having seizures ongoing. Big, big clue. We talk about prevention. It's right here. Without being too fancy, it's right here, not in remission. This is causes of death. 55% of the 60 were related to epilepsy, which means The other 43% were not. So about half were actually related to epilepsy. In the group that was related to epilepsy, 18 of the 33 were due to SUDEP. So the way that I was trained and the way that I used to think was wrong. You know, if someone would ask me this question 10 years ago, I would have said status epilepticus, maybe aspiration pneumonia. And that was just incorrect. The other point that came out is that 12 of the 26 of the non-epilepsy related deaths were due to pneumonia. And these were likely to be in neurologically disabled individuals. What's the point here? Pneumonia is preventable. And you know, the science is great, but what it's all about is prevention. So what this says is that in individuals who have respiratory problems, you know, acute attention to those problems and making sure they have so-called good pulmonary toilet is essential. And this probably relates a lot to residential facilities, so preventable causes. And this is just the summary slide to say that half the deaths were not in remission. A known cause of the seizures was very important, and SUDEP was the #1 issue causing deaths related to epilepsy. These are two earlier studies, both done in Canada, my new hometown, and first by Elizabeth Donner, and her data confirmed the fact that the majority were in individuals that had known causes. The Camfields in Nova Scotia found no increased risk of death if the child was neurologically normal, but a 22 increase if the child had neurologic abnormalities. So what I'm showing you is different kinds of evidence from different places and different times, all pointing to the same thing. And again, this is the list of children's studies that I mentioned at the low end of that graph. Okay, now what about other risk factors? And this is in medicine, we are blessed to have people that are willing to look through all the papers in the literature and put them all together so that you can see them all in one place, something that is difficult and tedious. And in this compilation, what I've done here is just put boxes around risk factors that were present in greater than 50% of studies, so more than a flip of the coin. And the two that I'm going to show you is high seizure frequency and high number of anti-epileptic drugs. These are what we would call surrogates for intractable epilepsy. Again, what's preventable about SUDEP? Seizure control. That's what it's coming back to over and over and over. Now, what about the kinds of seizures and when they occur? The so-called generalized tonic-clonic seizures are clearly the #1 seizure type that is associated with SUDEP. And that probably wouldn't have been a surprise to most people, certainly not to most doctors. What is frightening are the numbers that are required to increase your risk. And so if someone is having more than 3 generalized tonic-clonic seizures per year, their risk is increased by 8-fold. And you know, you'd say, boy, if someone's having 4 seizures and they're having 40 before, that's great. Well, it is great, except their risk is still high. It's also true that having 1 seizure a year doubles your risk of SUDEP. So the goal that you heard before, my colleagues, is our goal is 0 seizures. What about complex partial seizures? the non-convulsive seizures, it happens. I know families to whom have lost loved ones who've only had staring, unresponsive seizures. Not frequent, but happens. And the good news is for absence and myoclonic seizures only, there are no case reports. No individuals that we know of have had SUDEP. So that's what we know about seizure types. What about drugs? For about 2 years, based on some other work, there was concern that lamotrigine was associated with an increased risk of SUDEP. Lamotrigine is once you get past the initial risk of allergic reactions, one of the medications that has the lowest side effect profile, and therefore there's a lot of people on it. Guess what happened when lamotrigine as an increased risk for SUDEP came out? It was chaos in our offices. Get me off of this. But you're seizure free. Get me off of this, or my child. So there was, again, good research, good epidemiology by Dr. Hestorfer and group. And in careful analysis of the literature, the medicine fell off as a risk factor, but what appeared? Generalized tonic-clonic seizure frequency remains strongly associated with an increased risk of SUDEP. So, just like a few years ago in that presidential election, you know, it's the economy, stupid. For us, it's seizures, seizure frequency. Now, what about when the seizures occur? Does that make a difference? And the answer is we suspected it did. It seemed that most of this was occurring during sleep. But what was the data? This was one of the early papers. Look, 2012, not that long ago. And it was looking at 154 individuals with autopsy-proven SUDEP, well done with matched controls, and asking the question, are people with sleep-related SUDEP more likely to have nocturnal seizures? Meaning, if your seizures or your loved one's seizures occur more at night, are they at increased risk? And the answer, is here's three bits of data. First of all, you see the big green bar, number of SUDEPs. It's much higher during sleep and much less likely to be witnessed. The second is, when do these occur? Between 4 and 8 a.m. And this is a clue. And we're all going to hear in the next lecture about the importance of sleep and seizures. And this is a very hot topic. And the finding that was the question for the study, those who died during sleep were more likely to have a history of nocturnal seizures than those who died while awake. So nocturnal seizures is a big risk factor. We can put this data set together pretty easily in terms of risk factors. Intractable seizures, not controlled with medication, especially generalized tonic-clonic, a known or suspected cause for the etiology of the seizures, and seizures occurring during sleep. And when you look at this, and when my colleagues look at this, what that does is it should change us. Because when you see someone that you're taking care of that has these risk factors, what it does is make one very heavy-handed. And you can probably imagine, I'm very heavy-handed with my teenagers, frequently boys, who, you know, they're gonna go their way and do what they want to do. And I say to them at our first meeting, look, based on everything we know, you have these things. You must take your medication or you're at high risk of dying. Not a very pleasant doctor-patient family interaction. But overwhelming, and this gets done very soon. Now, what about the ethics of it? A lot of my colleagues were concerned about, the ethical considerations in this discussion. And in the world of bioethicists, this is how it's phrased. First of all, there's the medical right to know all potential complications of your disorder, particularly if they have implications for prevention. That's the medical. The ethical is full disclosure. You're supposed to say everything you know. And then there's the legal part to it, which is another issue that we could discuss. So far, not an issue in the United States, but has been in Great Britain. Dr. Nancy Collins is an epilepsy doctor, bioethicist in Chicago, who's written a lot about this, and this is a whole talk in and of itself. But what Nancy does is break it down into the bioethics and clinical ethics, principles and applications. Doctor's duty is to faithfully fulfill goals of medicine, and the whole thing of paternalistic versus shared decision-making models of the doctor-patient relationship. What Nancy emphasizes is that what doctors do every day when they use clinical ethics while caring for their patients is to weigh what should be done for the patient that would likely result in optimum benefit and minimum harm. That's supposed to be our ethical mandate. And when you go through the book that describes this argument, the conclusion is the increased risk of death, including SUDEP, associated with epilepsy should be disclosed as part of the overall education and counseling to patients about their diagnosis and prognosis of living with epilepsy, adapt to the needs of the individual patient. This is a fair statement. It does two things. The first is that it recognizes there's a lot to know about seizures and epilepsy, and SUDEP isn't done in isolation. The second and most difficult is adapt to the needs of the individual patient and family. What are the reasons you might not discuss SUDEP? And two that have been offered are if you knew, particularly in the adult world, that someone was depressed and anxious, and this information could cause them to be more so, then maybe you should defer to the conversation and do it with a mental health counselor. That's a good reason. What if the person's of a culture where the discussion of something is the same thing as wishing it upon them? And that's true of, in Canada we say First Nations, in the States it's still First Nations, the American Indian population, Native Americans. You got to be careful who you're talking to. Now, was this conclusion always the case? And the answer is no. In 2007, this discussion was brewing with the American Epilepsy Association and the Epilepsy Foundation, and we got together and had a relatively small meeting in Chicago to discuss the if, when, what, and how of do we discuss SUDEP on a routine basis, disclosure. And I will tell you, as you're reading the slide, that there was not unanimity in the room. And there were a number of very good, very well-intentioned people who said we should not be having this discussion mandated. We outvoted them. And one of the conclusions that came from this, and that I'll mention this again at the end, although I'm running out of, actually I have a few extra minutes because I was delayed, is that this discussion can be reassuring to those patients whose epilepsies are associated with very low risk. There are different groups of folks. My guess is that most people in this room either have or know people or have loved ones who do not have easily controlled epilepsy. That's just the way these meetings go. The vast majority of people who've had seizures do very well. And even in that group, there needs to be a discussion of SUDEP because they need to be reassured because we're talking about it in the media. And so the conclusion of the group was, it's not a matter of if SUDEP should be disclosed, it's a matter of how, when, what SUDEP should be discussed. And so that was sort of a big leap, you know, only in 2007. Now, what's the evidence? And this is where I think really the meat of the talk is. What do we think as professionals? And just to say it up front, sometimes professionals don't always get it right the first time. You probably know that, and it's not because of ill will, it's just because of training and bias and all the things that we grow up with. This was something from 2006, and this was a discussion that happened in England, and actually Great Britain, Scotland is included, and just to know, the British and the Australians have been 10 to 15 years ahead of North America in the discussion of SUDEP. Canada was about 5 years ahead of the States, and we're finally catching on. And this was something that was in the press. The National Institute for Clinical Excellence decreed that all patients treated for epilepsy should be told about SUDEP. These are called the NICE guidelines. And there's certain advantages to single-payer systems. Like, if you're paying for it, you sort of get to have to weigh in what should be done. And part of the NICE guidelines is the requirements for education in epilepsy. And discussing SUDEP in 2004 was one of them. I'll skip to that. And so what doctors Morton, Richardson, and Duncan did in 2005 is say, are people doing it? So they did a survey of Association of British Neurologists, open-ended questions, and had a pretty good response rate. What did they find? They found that almost 70% of neurologists either discussed it with very few of patients or none. 70% a year after it was put as part of their national guidelines. By the way, we do not have national guidelines in the United States or in Canada because we're rough individualists and no one's going to tell us what to do. Only about 30% discussed it with some or the majority. Why did they discuss it? Well, if someone asked, sometimes they did it spontaneously, sometimes they did it when starting therapy, subsequent appointments, only with recognized risk factors, and the key point was there's no systematic study of the views of the majority of people with epilepsy on whether and how they are informed. No one asked the people who suffered with epilepsy. This was another study done 2008 of the Epilepsy Nurse Association in Great Britain, and it won't come as a surprise that the nurses do much better than the doctors in discussing things. No enthusiasm from the audience. And that's really a key point. And the nurses didn't feel they should leave the discussion to the doctors because they knew their doctors and they knew they wouldn't discuss it. So I think this was a pretty revealing study. Now, here's the one that I think broke the field open in terms of our thinking about what we should be doing. And this was done in a regional pediatric epilepsy clinic in England, 100 consecutive parents and legal guardians. There were parent questionnaires done immediately after discussing SUDEP at the first visit and 3 months, and there was a physician questionnaire. I included these slides just to prevent someone from saying, well, this was just for specialty epilepsy clinics. It's not the real world. And basically, their clinic was the real world. How did the physicians respond? Well, more than half of them responded to the questionnaire. 28% given to all patients. Remember, this was a mandate from 2004. They weren't doing it. They did better with intractable epilepsy, 63%. But after what I've told you, this should be 100%. So 63% is not okay. Okay. 91% preferred to give personally. What's the implication of that? A lot of doctors do not want to hand off this discussion to anybody else. And this is a huge issue for a couple of reasons. Number one, as you know, our time in the office with families and patients is shrinking over the years, so we have less time to do more. And the second is maybe somebody else does it better, like our nurses who are trained to do it. And it doesn't even have to be a nurse, to tell you the truth. There are models where other care providers can give the information very reliably. The physicians thought 30% should be given at the time of diagnosis, and there's a whole discussion around what they thought the effect of giving this information would be. This is a slide that I'll go over quickly. This is the same kind of question given to the Italians at their convention. And what it showed was about the same. 30% were discussing it without a mandate. So not very good. And 70% weren't. This involves, and by the way, I'd be happy to make this information available to you because it's too much to see on a slide. 74% of the Italian neurologists thought it would have a negative impact on families. Again, this is doctor thinking. Okay? And only 14% said it's my medical duty, which ethically, I think, we've already discussed, that's wrong. And this is a survey done in 2012, almost 18,000 surveys sent out, only a 7% return. Not very good. And basically what it said is that 30% rarely discuss it, a third sometimes. Not very good in 2012. Why didn't they discuss it? Whoops. Well, because almost half said patient is at minimal or no risk, and another third said because there's no proven way to prevent SUDEP. Not right thinking. What did they report as the most common reaction? Anxiety, distress, only 20% appreciation. And years in practice inversely related to a negative reaction. Meaning if you take some young pup that has hair and give the information, not all mature physicians are bald. Doctors, no, thank you. That's not a good thing. Whoops. Okay. But basically what it's saying is the more mature you are, the more comfortable you are with the discussion, which tells me that my work should be done with younger neurologists. And you notice that although there's distress, there's very little true depression. It's hard stuff. Why wouldn't you be anxious? What do families want? And this is the same study that did the questionnaires for physicians, 100 consecutive parents, legal guardians. And this blew the socks off the neurologic community. First of all, very high completion rate for the first questionnaire, a little less good for the second one. 91% of parents expected the pediatric neurologist to provide SUDEP risk information. Wow. 67% of parents wanted the information at the time of diagnosis. Double wow. This is febrile seizures. This is childhood absence epilepsy. This is across the board. This isn't intractable seizures. So this was the clearest statement that what we were thinking as professionals was just out of tune with what our families really wanted. And this, a bit busy slide, looks at the impact of SUDEP disclosure. Remember, a lot of the docs were afraid that this would destroy the relationship in some way between the parent and the child, or add undue anxiety, or result in restriction of activity. And the bottom line, when you look at all of these things, is that that didn't happen. So again, the information is, number one, wanted, and number two, does not have a negative impact in the child relationship. Hi. Okay. And so this is the summary of what the docs were doing, were thinking, and what the parents were thinking. And this is real data, which I can tell you has had enormous impact in the pediatric neurology community. It's interesting, by the way, pediatric neurology, about 99% of the evidence is from families of children, not from adults with epilepsy. That hasn't appeared in the literatures yet. This is another survey about what people with epilepsy want and what their care providers want. And 68% of people living with epilepsy said, I want to be told regardless of my risk. Care providers of people living with epilepsy, about the same number, 72%. So more recent data and adult data. This is a study done in Canada by one of my colleagues in Ontario, where he did focus groups with families who've lost a child to SUDEP, moderate to severe epilepsy, mild epilepsy, new onset epilepsy. It's hard to do. The number of people involved isn't large. But let me just go right to the bottom line of the study. The discussion should take place and soon after the diagnosis, the first or second visit. The risk that families had was commonly overestimated because there's all this stuff out there on the internet, and so people think they have more anxiety, they have more risk than they do. A face-to-face discussion is preferred. Please don't just hand me a pamphlet that says read about SUDEP. Parents should decide if and when discussed with the child, very age and development dependent, and there's no resultant change in interaction with their children. So again, pretty good evidence. And these are some of the other conclusions. So based on the evidence, it is clear that parents, caregivers, patients want to discuss SUDEP, and most providers don't want to. But how you do it, when you do it, and why you do it is not so clear. So the bottom line for this part of it is, whoops, it's out of order, but what about empathy? And I'll give you my 2 empathy slides. This is Chris Donalty. Mom is Jean, who's been a major player in making everything happen in the States with regard to SUDEP. Why? Because in the early days, I was so afraid of Jean that I had to do something. And Chris's story is all too common. He was diagnosed as a senior in high school. He was told it was a benign disorder. He went away to college, had some seizures, had his medicine changed, had some adverse effects, had his medicine changed, and said he was told his mom he was seizure-free. He had continued seizures, did not tell his mom about it, and he was found dead in 2002 in college. And when Jean wrote about this to me, and this is with her permission, there is nothing worse than losing a child, no matter the age or cause. But a sudden death out of the blue, something that you were never told could happen, somehow makes it particularly cruel. All the unanswered questions, the what ifs. And what Jean was saying, and she's an enormously reasonable person, she says, I don't know if it would have made any difference in the world, but maybe if I knew, maybe if somebody told me, maybe I would have yelled at my son enough to make sure he was taking his medicine, or at least let me know that he was having seizures so we could do something else, whether that be another drug, surgery, vagus nerve stimulator. And this is a theme that I've heard over and over and over again to push the reality of having the conversation. So the summary is there's a strong ethical basis for discussing SUDEP with all families, patients, that can and should be modified based on individual patient-family needs. Professional standards are leaning towards disclosure based upon evidence of prevention by facilitating decreased seizure frequency, and families want to discuss SUDEP soon after the diagnosis. Not to mention, it's just the right thing to do. So for the high-risk group, the intent of the conversation is compliance with whatever intervention is needed. Timing at the first office visit, repetition as often as you see these folks that are maybe not compliant and still having seizures. What's the specific intent in the low-risk group, and that end over here that's very unlikely? It can be reassurance. I can't tell you the number of times I've looked at a parent's face after I've told them, good news, your child's had one febrile seizure, don't worry, and it's always the mom looking back, totally unconvinced, and I'll say, what's the issue? She'll say, I'm afraid my child's gonna die. So you gotta bring it up. And that's the unasked question. So what can you do? Well, you are blessed in this community with SUDEP Northwest. You are out there making knowledge available. That is huge, and I will tell you that this doesn't exist in many, many communities across the United States. You have the Epilepsy Foundation that now has the SUDEP Institute. You know, of all the things EF does, SUDEP is a big part of it. Yay. And it is a institute that's put together with a lot of stakeholders, the most important stakeholder being you. They have an enormous amount of information that's available that you should take advantage of. And what else you can do? The North American SUDEP Registry. This is a year old, and it's basically to put together information about people who die related to epilepsy. Doctors cannot contact Nasser. It has to be done by family members. It's done in as sensitive a fashion by as good a people as I know. It's very important to do it soon because things change and tissue changes, looking for genetic studies as to what the cause could be. A very difficult time to do it. And as you've heard, there's the Partners Against Mortality in Epilepsy. We had our first organizing committee meeting for the 2016 meeting. It's probably going to be June 23rd to 26th, and I regret to inform you, those East Coast pseudo-intellectual snobs want it on the East Coast. I'll argue for the West. So with that, I thank you very much for your attention. I'm way out of time, so I'm happy to do anything now or after 4, whatever.
There's a question. That'd be great.
Question or two?
Is there a question for, there we go.
So is SUDEP only diagnosed as an actual diagnosis when an autopsy is done?
No. If there are other criteria met, like the person didn't have an underlying cause, like it was thought to be related to a seizure, a diagnosis of probable SUDEP can be made. So it's best to have it done, but if not, those new criteria allow it under probable.
So my son has several risk factors: daily seizures, 3 medications, and seizures in his sleep. So what can I do to prevent SUDEP from happening to him?
Yeah, that's the question. And there's two kinds of answers, which if you want we can discuss more quietly. But I think number one is being very aggressive about therapies. And despite the fact, say, is it possible to go through 16 medications? And the answer is, if you have to, that's what you do. If his physicians think the ketogenic diet would be useful, go for it. If he's possibly a surgical candidate, consider it. So that's that whole stop the seizure thing. And then there's this whole other body of literature that's out there regarding warning devices. None of them have been demonstrated to prevent SUDEP. Each of them carries with it pros and cons in terms of false negatives. And and I'll just very quickly mention one. Those devices that go off very quickly at any sign of badness are similar to the apnea monitors that were used 20 years ago to try and prevent SIDS. And what happened was they went off so frequently and disrupted so much of family life that people basically stopped using them. If you said, well, I don't care, I'll get up. The negative part for that about seizures is what's one of the biggest risk factors for having more seizures? Disrupted sleep. So in looking at those devices, one has to be very careful that you may be that you get more good than harm.
Of the risk factors you mentioned, is there one that weighs more heavily towards the probability of it happening?
Yes. Uncontrolled generalized tonic-clonic seizures. Next one, having them during sleep. Absolutely.
When have you found it appropriate to tell the child? You joked about the adolescent teenage boys, but when do you find that children are able to digest this kind of information?
Yeah. So the question is when, at what time, other than the ones that I'm hysterical about, the teenage boys with uncontrolled seizures. And it's the balance between, I think parents should be the primary, determinant of when that discussion is had with their kids. I try and do that in a tricky fashion, like say to the child, okay, we're going to go out of the room now so I can watch you walk, which I do as part of the routine exam, and then ask the parent what they think they want to do, and I usually try and bias it for discussion with the child in the room, because a lot of kids are smart, a lot of kids know that something's being discussed behind their back, and that doesn't usually go well. And some kids, 10, 11, 12, be amazed at what they know and what they've read on the internet. And sometimes someone will come and say, my son's afraid that he's going to die. So those are sort of the rough